Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 250 of our pharmacotherapy series, which majors in infectious diarrhea. The first question reads, HIT, a 76-year-old man with multiple medical conditions, is admitted to the same 10-bed hospital ward as BMW in part 249 of this series. HIT's medical history is significant for a stroke that has left him bedridden in a nursing home. His only medications are those used to manage his hypertension. On day 4 of his hospitalization, HIT complained of severe abdominal pain and watery, loose stools with blood. Physical examination revealed an ill-appearing man with a temperature of 101 degrees Fahrenheit and hypotension. His WBC is 21,000 cells per milliliter. A stool specimen is positive for Clostridioides difficile toxin, and colonoscopy reveals pseudomembranes and colitis. A surgical consultant is considering an emergent colectomy because of possible bowel perforation secondary to the Clostridioides difficile infection. What are HIT's risk factors for acquiring Clostridioides difficile associated pseudomembranous colitis during his hospitalization?
HIT's risk factors for acquiring Clostridioides difficile infection include his advanced age, bedridden status, underlying diseases, and admission to the hospital. Clostridioides difficile infection is spread when hospital personnel or equipment contaminated with Clostridioides difficile spores come into contact with susceptible patients. Physical proximity to an infected patient has been associated with an increased risk of Clostridioides difficile infection. Therefore, measures to prevent the spread of Clostridioides difficile infection include hand disinfection before and after contact with infected patients, the use of gloves and gowns, enteric isolation precautions, and proper hand washing with soap and water to remove any potential spores after contact with infected patients with Clostridioides difficile infection. Contaminated equipment should be properly disinfected. Although Clostridioides difficile is often thought of as a nosocomial pathogen, it is being increasingly isolated in outpatient settings. This changing epidemiology has led to a standard definition of community-associated Clostridioides difficile infection in patients without any healthcare facility exposure within the last 12 weeks. While many community-associated Clostridioides difficile infections appear in patients without antimicrobial exposure, antimicrobial use remains the highest risk factor. Although proton pump therapy and other acid suppression has been increasingly suspected as a cause of these infections, a meta-analysis of community-associated Clostridioides difficile infection did not find acid suppression to be a significant risk. However, corticosteroid use was associated with the disease.
The next question reads, over the next few days, all 10 patients on the ward with BMW and HIT are found to have Clostridioides difficile toxin in their stools. 5 patients have diarrhea and the other 5 are asymptomatic. What is the role of antibiotic therapy directed at Clostridioides difficile in controlling this outbreak? Neither oral metronidazole nor vancomycin is reliably effective in eradicating the carrier state, i.e., asymptomatic fecal excretion, and neither is recommended for use in this situation. The lack of efficacy of these drugs is probably because of the fact that, unlike the vegetative forms of Clostridioides difficile, the spores of Clostridioides difficile are resistant to the action of antibiotics. Furthermore, compared with placebo, vancomycin administration is associated with a significantly higher rate of Clostridioides difficile carriage 2 months after treatment. Controlling overall antibiotic use in the hospital can be a useful strategy. Antimicrobial stewardship is increasingly seen as a major control mechanism for Clostridioides difficile infection. Restricting the use of single agents like clindamycin can be an effective component in efforts to control nosocomial epidemics of Clostridioides difficile infection. With the emergence of the BINAP1 strain, control of all antibiotic use, especially fluoroquinolones, may be important in outbreak control. Finally, the overuse of acid-suppressive therapy in the hospital setting, particularly proton pump inhibitors, has been linked with increases in Clostridioides difficile infection. Efforts to control use of these drugs have been increasingly recommended. The next question reads, what effect will the current Clostridioides difficile infection outbreak have on the outcomes of the infected patients and on health care costs? In a prospective study, hospitalized patients who developed Clostridioides difficile infection had a 3.6-day increase in length of stay. A large retrospective cohort study in the Veterans Affairs Administration in the USA reported a 2.3-day increase in hospitalization, with an increase of 4.4 days with severe disease. A review of available economic data suggests additional hospital costs of $8,900 to $30,000 for each case of Clostridioides difficile infection. The current outbreak on the hospital ward is likely to increase both hospital costs and individual lengths of stay. The next question reads, what treatment is recommended for HIT who is critically ill from a Clostridioides difficile infection? What criteria should be used to characterize patients as critically ill? Up to 57% of patients with antibiotic-associated pseudomembranous colitis who require surgical intervention, colectomy, die. Although the precise definition of critically ill is not clear, it has variably included patients with pseudomembranes, age over 60, serum albumin 38.3 degrees Celsius, severe abdominal pain, and marked leukocytosis greater than 15,000 to 20,000 cells per milliliter. Recent guidelines from the Society for Healthcare Epidemiology of America and the Infectious Disease Society of America have suggested the definition of severity as presence of any of either of the following two parameters: white blood cell count equal to or above 15,000 cells per milliliter, or serum creatinine 1.5 times baseline. Growing evidence suggests that vancomycin 125 mg orally 4 times daily may be more effective than metronidazole in patients with predefined severe disease. An additional definition of severe, complicated disease has been suggested for patients like HIT, who have hypotension, shock, ileus, or megacolon. The recommended therapy for HIT would be a combination of vancomycin 500 mg orally 4 times daily and metronidazole 500 mg intravenously every 8 hours. This combination therapy was shown to reduce mortality from 36.4% to 15.9% when compared with monotherapy in a small observational study. The combination of high-dose therapies is theorized to overcome the difficulties for either medication to get to the site of action in the colon. The next question reads, 3 days after oral vancomycin and intravenous metronidazole is initiated, HIT develops an ileus and cannot take anything by mouth. What therapeutic options are available to treat HIT's pseudomembranous colitis? Adequate antibiotic levels in the colon are necessary to treat Clostridioides difficile-associated pseudomembranous colitis. If the oral route is not feasible, e.g., patients with an ileus or bowel obstruction, the clinician must choose an agent that is either secreted or excreted into the GI tract in its active form. IV vancomycin is not a desirable agent in this situation because it is not secreted into the GI tract. In contrast, intravenous metronidazole is eliminated by both renal and hepatic routes, and bactericidal concentrations are achieved in both serum and bile. The literature contains few reports of successful attempts to treat Clostridioides difficile infection or pseudomembranous colitis with IV metronidazole 500 mg every 6 to 8 hours alone. Likewise, unsuccessful attempts to treat Clostridioides difficile infection with IV metronidazole have been reported. The clinical response of Clostridioides difficile infection to oral vancomycin in a patient who did not survive was difficult to ascertain. In adults, enteral vancomycin 500 mg 4 times daily can be given through an ileostomy or colostomy, if present. Several reports of successful outcomes using intracolonic vancomycin as an adjunct to oral or IV antibiotics in patients with Clostridioides difficile infection have been documented. Rectal doses of vancomycin have varied from 500 mg every 4 to 8 hours to 1000 mg per liter every 8 hours. Rectal vancomycin administration volumes of 500 ml are suggested to better ensure delivery to the transverse and distal colon. Saline can be used as a carrier, but electrolytes should be monitored because absorption can occur. Lactated Ringer's solution may be preferred if hypochloremia is present. Because patients with Clostridioides difficile infection are at risk for colonic perforation, enteral vancomycin should be administered cautiously. The next question reads, PEV is a 57-year-old male who acquired Clostridioides difficile infection on the same ward as the other infected patients. PEV was treated with metronidazole 500 mg orally 3 times daily for 10 days while in the hospital. 1 week after discharge from the hospital, PEV once again developed abdominal pain and diarrhea. His clinic physician assumed these symptoms could not be related to a relapse of his Clostridioides difficile infection because he had responded so well to metronidazole. So my question to you is, what is the likelihood that Clostridioides difficile infection has recurred? Regardless of the antibiotic regimen prescribed for Clostridioides difficile infection, symptomatic relapse occurs in 5% to 30% of patients who respond to their initial treatment regimen. Relapses occur 2 weeks to 2 months, median of 7 days, after treatment has been discontinued. In most instances, relapses are caused by germination of dormant spores that are intrinsically resistant to antibiotics. Reinfection with Clostridioides difficile from external sources, however, may account for up to half of all second episodes. In rare instances, either vancomycin or metronidazole may have caused Clostridioides difficile infection. Risk factors for recurrent Clostridioides difficile infection include increasing age equal to or above 65 years, use of proton pump inhibitors, renal insufficiency, continued use of antimicrobials during Clostridioides difficile infection treatment, and glucocorticoid use. Data suggest that patients with a poor immune response to Clostridioides difficile toxin A are more likely to have a relapse of Clostridioides difficile infection. It is not clinically helpful in the case of PEV, because no standard tests are currently available for this immune response. The influence of the immune system, however, has led to the usage of IV immune globulin in refractory or severe cases of Clostridioides difficile infection. The utility of the usage of immune globulins has been debated in small single-institution reviews. Immune globulins would not be considered the next line of therapy for PEV. The last question reads, how should PEV's Clostridioides difficile infection relapse be treated? Most infections resulting from relapse are not related to bacterial resistance, and they respond to retreatment with the same antibiotic used for initial treatment of the Clostridioides difficile infection. Thus, an appropriate approach for PEV is to administer another 10 to 14-day course of oral metronidazole. For patients with multiple recurrences of Clostridioides difficile infection, the optimal management plan is unresolved. Different approaches have been tried, including a high-dose oral vancomycin, that is 2,000 mg per day. B. A 4 to 6 week course with vancomycin, after which the dose is tapered over a 1 to 2 month period. C. Exchange resins with or without antibacterials. D. Pulse dosing of vancomycin every 2 to 3 days, or E. A combination of vancomycin and rifampin 600 mg orally twice daily. Tapered and pulse therapy with vancomycin were shown to be most effective in a clinical trial comparing multiple strategies. When combined with standard antibiotic therapy, a clinical trial with the probiotic Saccharomyces boulardii for cases of relapsing Clostridioides difficile infection noted a 65% response rate versus a 36% response rate for combination therapy with placebo. The relapse rate was reduced to 17% when Saccharomyces boulardii was combined with high-dose vancomycin. Following treatment with vancomycin, a chaser course of rifaximin, a poorly absorbed rifamycin derivative, was successful in separate case series for patients with multiple relapses. Concern must be raised that the single failure occurred in concert with emerging rifaximin resistance. Because of its more minimal impact on fecal flora, fidaxomicin may be recommended for recurrent infections, although there is less evidence for its use in recurrence compared to other recommended agents. Fidaxomicin's inherent advantage in limiting recurrence with initial treatment and treatment of first recurrences may lie in cost savings. Finally, fecal microbiota transplant, abbreviated as FMT, therapy has been more widely investigated in second and third relapses and has shown significant promise. Healthy fecal donors, often family members, are the usual source for fecal microbiota, though frozen banks of fecal microbiota transplant samples have been increasing. Administration of fecal microbiota transplant can be provided through nasogastric or nasogastrojejunal tubes, colonoscopy, or colonic enemas. Although published data overall remain small, a systematic review of the literature supports the efficacy, with 85% cure rates, and limited adverse effects of this therapy. Long-term follow-up from a multi-center study of 17 patients found 88% to 94% success rates. A single cost-effectiveness model, using literature-based data, found fecal microbiota transplant to be more cost-effective compared to treatment of recurrences with vancomycin. Thank you.